So till now we saw what is available, and next we are coming to the future trends, emerging technologies and innovations in the management of astigmatism. So what we have, we saw the manual methods. Now we are going to smart manuals, something coming up, toric guidance systems, which we have, the role of capsulotomy. Then something even more interesting, which is light adjustable IOLs, something perfect lens technology, and lyric. So what are smart manuals? Manual is basically you are doing the manual marking and trying to calibrate it with using some smartphone apps. The most common one in India which is being used is iToric Patwardhan. This is a free app which is available on iOS as well as Android, and it has been developed by Dr. Saurabh Patwardhan. It's excellent in terms of usability, but requires a trained person to operate. So this is how you basically use iToric for doing a manual marking. You mark freehand, and once you have done the marking, you have to take a picture. The iToric Patwardhan gives you this kind of protractor over the image. You have to adjust the protractor and pinch the cornea, pinch so that the cornea fits in the outer circle and the center of the pupil. Then you have red marks, which these red dots that you have to align with your ink marks. So these red dot, from the position of these red dots, the iToric Patwardhan gives you exactly where your marking is and what kind of error that you have induced while marking for this particular patient. And from that you can recursively calculate, and it recursively calculates and shows you where your IOL is supposed to go. This is another software that actually we are developing. This is gonna be called Precision Toric Anywhere. It is right now in a pre-launch phase. The system is similar to Saurabh Patwardhan's system, in which you do your ink mark as per your routine practice. You can do 3 ink marks, you can do 4 ink marks, you can do 360-degree ink marks. It doesn't really make a difference to this software. Once you have done your ink mark with either using a pendulum marker, or you're doing it based on slit lamp, or you're using a bubble marker, the app will be provided with on Android. You have to take a baseline photograph, and during this baseline photograph the patient needs to fixate on a distant vertical object, and this photo is uploaded over the internet to our server. The server has all the logistics to take care of where these ink marks are. So it will process and it will give you back the images. So this is a short demonstration of the upcoming Precision Anywhere. We're just trying to, parody the cashless anywhere that government is saying but not implementing. So this is a parody of that cashless anywhere. You do your ink marking, and after that with the app, you can hold the mobile anywhere, anyhow. It just has to be on a vertical orientation. Take multiple pictures, 3 or 4 pictures of the patient. This is a ring illuminator which we use to have a good quality image. Basically, the only thing it does is it provides a good illumination for the photographs to be taken. Once the photographs are taken, you have to attach the demographic data. You select a photograph, attach the demographic data. So the patient name, the patient MRD number, and the patient's eye, and then it is uploaded to the internet. Once it is uploaded, this is the image that you get back from the software. So currently the software, the protractor is going to come, but currently the software is going to identify where the limbus is. So this is a step which in Dr. Saurabh's system as well as in other systems you have to do manually. In our system, the whole thing is going to be automated. So the limbus is going to be identified where the limbus is. It is going to identify where your ink marks are. So let's say this ink mark is at 0.1 degree. For demonstration purposes, the ink mark here are made in the computer, but it basically recognizes this ink mark as 0.1 degree. So it is fairly good ink mark. It was supposed to be at 180. 0.1 is not bad at all. And in these 4 other ink mark locations are demonstrated. So now you have 4 places where your Mendes ring, you can put your Mendes ring and have a intraoperatively. You can just verify whether your ink marking is proper or not. This software is under development right now, and would be available in about a month for download. So the beauty of this thing that we are planning to devise is there won't be any hardware required apart from a smartphone. You can use whatever manual method marking you are using, even freehand marking works. And we provide the robotic precision over the internet. And we are planning to make it extremely affordable, cheaper than your viscoelastic. Another smartphone-based app which is available is Jetwa Toric Marker. This also works similar to Saurabh Patwardhan's marker, which basically gives you these radiating lines with where you have to coincide these this central circle with your limbus. Coming to MNC automated systems, you have Zeiss Callisto I with integrated with IL Master. This is an automated markerless system. The single unit captures everything, and the system matches the accuracy and provides you a live guidance with an accuracy of 1 degree. The pros of this system is it's a system which requires a very minimal training. It's a gold standard system with proven track record, completely non-contact with minimizing operator errors since the data moves transparently, and it's compatible with select EMRs in case you require the data to be used later. The major disadvantage of this system is the cost. It costs about 80 lakhs rupees, 70 to 80 lakh rupees for the hardware, and then other parts limited to a single system. So even institutions find it difficult to have multiple. Works with Zeiss microscopes only. Alcon also has a system which works with other microscopes also, but this is a limitation of Zeiss. And still, even with a Callisto or Varion, the errors can creep in terms of if your reference image is poor, if you have significant conjunctival chemosis, if there is a large subconjunctival hemorrhage, and extremes of anatomy like deep set eyes and narrow palpebral fissure, along with a very badly uncooperative patient. So this is basically how the Alcon system works. It identifies the limbus, it identifies the blood vessels around the limbus that has there in the preoperative baseline image, and from that it calculates where your toric IOL should go. Another system which is available is Alcon Varion image guidance system. It is again a markerless system, and this requires a reference unit. This reference unit does not provide you biometry, but it actually calculates all of your corneal and limbal anatomy beforehand. And your Alcon Varion provides you with a vision planner which allows you to have multiple incisions and calculate the effect of all of those incisions along with astigmatism management for your astigmatism management. We have a second system which is currently in the market. This is called Precision Toric Guidance System. This is basically similar to Alcon Varion and Callisto. The previous system that I had shown is internet based, so anybody without any kind of hardware can use this, while the Precision Toric Guidance System requires you to have specialized hardware. Basically it requires you to have a computer attached in your OT. This requires a single mark. The Precision app, you can have multiple marks, and the multiple marks will be tracked and you will get a data, but there won't be any live data intraoperatively. Precision Toric Guidance System gives you live real-time guidance. So again, the baseline system, the basic working of the system is same. In this Precision Toric Guidance System, you just do one mark, while in app you can do multiple marks. Baseline photo is taken, and this photo is used by the system for guidance. Video has not come. Okay. There's another system in development by Dr. Jagdeep Kakadia. It is called LaserX, but it is the details of which is not available as of now. Then if you are lucky one having access to a femtosecond machine, Lensar comes with a femtosecond laser platform in which the capsulotomy comes with these small tags. So these small tags are there forever. You just have to align your toric IOL to the tags, and these are created during its capsulotomy system itself. So probably the easiest thing to use. But again, mainly the problem in India is cost. Capsule laser is a very, very interesting and very exciting thing. It doesn't do anything for you in terms of toric marking, but it provides you with a very nicely centered, very precisely controlled capsulotomy. The beauty of this is again all of your toric results are dependent on your post-op fibrosis. So if the post-op fibrosis is more, post-op IOL rotation is more, then all of the things that you have done previously go down the bin. Coming to the more even more exciting things, there's something called light adjustable IOL that is FDA approved in 2017. The company says test drive your vision. What do they mean by that? You basically put a light adjustable, you do your calculation, put a light adjustable IOL in, ask the patient to wear UV blocking glasses for some time, and later on you can have multiple sessions in which you can change the refractive power of the IOL. You can change the spherical equivalent of the IOL, you can change the toricity of the IOL, and this can be done in multiple sittings. Once the patient is satisfied with the IOL, the entire IOL needs to be exposed to their UV machine, and that locks in the treatment. So this is the study that LAL have published, in which the spherical correction, the adjustment they were able to do was from -2 to +2, and cylinder from 0.75 to 2 diopters. So basically it takes care of most of your astigmatic surprises as well as your spherical surprises. After adjustment, 92% of the spheres were within 0.5 degrees, 82% of the cylinders were within 0.5 degrees. While in even more exciting was in post-refractive eyes, 74% patients were within 0.25 and 97% patients within 0.5. So I don't think there is any other technology which gives that kind of precision to us. The cons, it is a significantly costly affair. Even in Europe, where it is available, it costs about 4,500 euros more than your average surgery. So converting that to Indian rupees, you would get approximately 2 lakh rupees per eye, more than what is going to cost the patient otherwise. It requires a minimum pupil dilatation of 6.5 to 7, and the patient needs to wear a UV block till the final lock-in is done. Otherwise, God himself will lock everything in. So that's a big problem. This is another system that is again very, very exciting. This is a perfect lens tech. It allows they are saying that they will be able to in vivo modify any intraocular lens that you have already put in. What they do is they change the refractive index of the lens itself. They're using a femto laser to cause photo-induced hydrolysis of the IOL material itself. So you are actually disrupting the IOL material itself, and as a result of that disruption, your aqueous will seep into the IOL and it will change the refractive index of the IOL itself. So any IOL that you have put in, you just change the power of that IOL. Refractive index change of 0.01 provides 3.3 diopters of actual change. For our normal cataracts, we only know of the millimeter change in axial length. 1 millimeter change in axial length is going to cause about 3 diopters of change in refractive power. Here, a 0.01 change in refractive index of the lens allows 3.3 diopters of actual change in the IOL. It works with hydrophobic as well as hydrophilic lenses, and again it is infinitely repeatable. This is their study in which and they claim that they are able to change a multifocal to a monofocal and a monofocal to a multifocal. So this is their study in which they have published. The patient began with the trial eye began with a multifocal lens of 20.85 with an add of 3.58, MTF of 0.37 and 0.26 for distance and near, and ended up with a monofocal of 21.04. So you started with a 20.85 multifocal, you ended up with a monofocal of 21.04, and you also have the option of again repeating the treatment on the same IOL. This is something really, really exciting. Second, they started with a monofocal of a 5.27 diopter with an MTF of 0.53 and ended up with a multifocal of 5.25 and 8.83. So I have 3 diopters add, and the split is also nice at 51:49. So a little more than what we are used to for near, but still you start with the monofocal and end with the multifocal, and the possibility of repeating this also. So this system, I think, is the most exciting to any person who's having access to a femto laser kind of machine. The cost and other things are not really available right now, but it is under development. Lyric is another system which is again based on femtosecond, but here instead of tackling the lens, they are tackling the cornea without opening the cornea. So what Lyric is doing, very low threshold, below the ablation threshold, to basically alter the corneal shape without disrupting the epithelium itself. So what they are doing is they are creating a lenticule within the cornea itself without cutting the lenticule out, and they are claiming to use it as a first line therapy to treat any kind of myopia, hyperopia, as well as for higher order aberrations. It is neither an additive nor a subtractive procedure. Just whatever layer and the thickness that they say in which they are altering the cornea is just 10 microns. So I don't think even our most efficient smile machines or any other clear machines or any machines can go up to that level. And this again is a repeatable method, because you can just go to a higher or a lower, higher or a below corneal layer and repeat it. But both Perfect Lens as well as Lyric are yet to be FDA approved. So thank you.